Welcome, everyone. Welcome, everyone. And, as Julie told you, we want to keep this informal. So I'm happy to answer any questions that you have on any topic having to do with health insurance, because that's what I'm here for. If you want to just schedule something private with me, we can do that as well. So I want to start today talking again about one of my favorite topics, which is in-network and out-of-network. And I know we talked about this, I think last month and maybe even the month before, but this seems to be becoming a bigger issue, and we're getting a lot of inquiries about this topic. So recently, for example, someone contacted our firm and said that she had had a surgery. She had called the hospital that she was going to have the surgery at to make sure that the hospital was in network. The hospital said it was in network. So she went ahead with the surgery. And then it turned out afterwards the hospital was wrong. They were not in network. And now she's getting, higher bills. And remember, as we talked about before, when you have a PPO policy, the key difference between in-network and out-of-network is, first of all, an in-network provider has agreed with your insurance company what they're going to charge. So they know when you come in, if you're coming in for a particular procedure or a particular hospital stay, this is what they're going to get. They know they're going to get it, and they can't balance bill you any additional amount. You're still responsible for your co-pays and deductibles, but there's predictability. An out-of-network provider has not entered into an agreement with your insurance company, and so you don't really know what your insurance company is going to pay. And there's a lot of fuzzy language in insurance policies that give the insurance company discretion or the ability to pay less, and then whatever they don't pay, the provider can bill you. So it's a really big deal, especially when you're having a large procedure. So I was thinking about this person who contacted me because, it seems like she did everything right. She called the hospital. They said they were in network. And now they're saying they're not, and now they're trying to bill her. She did not, however, and this is the key, call her insurance company or confirm with her insurance company. Now, we all know, or we've talked about this before, so I hope you all know that you can check out the lists that your insurance company has online, who they list as in network or out of network. You can do that by going through your portals. The problem, as we've discussed, is that these lists are out of date. And the insurance companies are not bound by them. We have found this many times that if they list a provider and then they make an error, or the provider is no longer in network by the time you reach that provider, they're not bound by what they put online, which is extremely frustrating. The other thing, though, that seems to be happening, and especially in California, is the question of what network are you looking at? So I will tell you that at Kantor, I'm responsible for what health insurance our employees have. And I recently moved us from Anthem Blue Cross to Cigna plus Oscar. Almost primarily because it was saving our people money. And enough money that I think it made sense. And my impression of Cigna versus Anthem is that, they're generally compatible. I don't have a problem with Cigna's coverage decisions in general. I mean, they're an okay company, I guess. Okay among a lot of bad actors. But the issue is, and I'm learning this as we all move through this, and with the people who are talking to me, is what network is Cigna using? Well, it turns out that my employees who have the Cigna PPO, who chose that, are using the Cigna network, and Oscar, which is a company Cigna created in California, is the administrator. My employees who got a EPO, they're using the Oscar network. Now, why does that matter? Well, it happened to matter to me recently because I went to get some vaccinations I needed because I'm actually going out of the country next week. And I went to this travel vaccine place and they said, oh, we're in network with Oscar. We're not in network with Cigna, which I found really interesting and surprising. I've also looked at cases where people have an Oscar policy, so their card will say Oscar, but they're using a different network like Providence or something else. So now you not only have to look at what insurance you have to look at what network they're using, which is just a lot of work to do to try to get yourself healthy. So going back to this woman who contacted me, I was thinking, okay, if she had come to me beforehand, what would I say to her? Or what advice do I have for all of you if you're worried about this? Now, first of all, as you know, Joyce brought up a couple of months ago, there is protection in California under the Surprise Billing Act now. And you're not supposed to be, for example, you're not supposed to go to an in-network hospital, have a procedure, and all of a sudden get an out-of-network anesthesiologist bill. And if you go in network, you are entitled to expect that everybody who treats you is in network. I mean, wouldn't it be odd if you need a cardiology consult while you're in the hospital and that cardiologist charges you as an out-of-network provider? No one would expect that. But more importantly, how do you make sure the whole hospital is in network? I mean, is calling enough? And, I have to say, the more I thought about it, calling's not enough. We have this expression that we use in our ERISA cases. And remember, ERISA is the law that governs those of you who have employee provided policies. We say if it's not in writing, it didn't happen. And that came out of the fact that we've talked about how in ERISA law, everything that the judge is going to do if you bring something to court is based on what's in writing in the insurance company's file. So I thought this is really good advice for us to take and for me to give you on this in-network, out-of-network issue. So here's what I would think I would have told this woman if looking back at her situation. It's okay to call and say, are you in network or out of network? But then what you have to do is follow up in writing. And what you need to do somehow is confirm that you're having the surgery, you understand the hospital's in network, and you're choosing the hospital because it is a network, and you wouldn't choose the hospital if it was out of network. Now, that just may sound really silly to you, but I think if you're really going to be able to do something with that, if they change your mind, you have to somehow put that in writing. An email is perfectly fine these days. So if you can find an email address of the person you spoke to, you can ask, can I have your email address so I have it for my records, and just shoot an email. Or you can just put it in writing and send it through your medical records folder, or through the U.S. mail. As I say, people don't realize the U.S. mail still exists and still works, and it's very effective for these things. But the other thing I would tell her too is I would call the insurance company. I would call the insurance company, ask them, and then confirm with them too. It's a little easier to confirm with an insurance company because I'm hoping at this point, the one thing you've taken away from listening to me is you should be on your portal, you should be checking your claims, you should be, you know, tracking what's going on. And it's really easy to send messages through a portal. And so never fails whenever I need to talk. Hold on, I'm gonna close my door. That's my kennel talking. You can send a message through your portal and say, you know, I just got off the phone with Donna. They never give them last names. And she told me that, you know, ABC Hospital is a network, and that's why I'm going there, because I want to use an in-network facility to have my surgery. Now, we've never tested this. This is a new issue that's coming up. But I think this would be what I would say would be best practices if this is what we're going to do, if this is what is needed. And it sounds like that's what is becoming needed, that determining and protecting yourself that you're using something in network is much more complicated than a simple phone call. I see Joyce is asking, you know, would you send letters, return receipt, or delivery tracking? You know, I don't really think you have to. Certainly it is fine to do so. We have what we call in this country the mailbox rule. If you put it in the mail and you mailed it, it assumes that it got where it was supposed to go. I would of course keep a copy either in your you know, in your computer is fine. So you can say, I, you know, walked to the mailbox, or I put it in my mailbox and I sent it. If you're really worried, of course, a return receipt or some delivery tracking is always good practice. And if, you know, if you've been in this situation before where you've gotten bad information, then sure, you know, I think it's a great thing to do. So we'll be talking a lot about in-network, out-of-network in these seminars, because I think this is one of the hot topics that's going on in the healthcare field right now. I mentioned last month, and I just want to mention it again, some of the reviewing agencies like the Department of Insurance or the Department of Managed Healthcare and the Department of Labor are becoming aware that a lot of insurance companies have what we call ghost networks. And so they'll have this robust list of, you know, cardiologists in your area, but when you drill down into it, or when somebody does, there are errors, or they no longer in a network, or they're not taking new patients. There are regulations that require insurance companies to report their networks every year, and they are supposed to ask for exceptions if they can't find someone in network in an area in a particular specialty, you know, like a remote area or something like that. I think it's an area that the regulatory agencies really need to spend more time on, because they're accepting these reports and not really looking into them. Who they report to depends on the type of coverage. In California, we have a bifurcated process. Our HMOs and what we call the blues, most of the blues, Anthem, Blue Cross, Blue Shield, report to the Department of Managed Healthcare. Our traditional insurance companies, PPOs, report to the Department of Insurance. And the reporting requirements on networks are similar. There's parallel statutes. You know, if you ever had absolutely nothing to do, you could go online and look at what your insurance company reported for the last year in terms of their network availability. I mean, who's in their network? It's probably pretty boring stuff, but I've looked through it before to see and assess networks. And what I've never seen is either one of those agencies coming back and saying, you really haven't done enough here. And I find it hard to believe that every insurance company always has enough information. So I don't know if there are any more questions on in-network, out-of-network. We'll talk about it, as I said, a lot in these seminars.
There was a question by Joy, and it was referencing who do they have to report that to? So Joy, I'm not sure which part. Lisa, do you understand her question?
Yeah, I was hoping I just answered it, but depending on
Right.
whose jurisdiction they're under, determines who they have to report to. Yeah. So if you have and just to add to that, so some companies, for example, Blue Shield has two companies. One reports to the Department of Managed Healthcare, one reports to the Department of Insurance. The managed healthcare company is actually called Physician Services of California, which nobody knows because it's a DBA for Blue Shield, or Blue Shield is a DBA for that company. So your insurance policy should tell you which company they're reporting to, which regulatory agency they're reporting to. As I mentioned before in other months, on the mental health side, this is the most challenging. We are still, as a nation, deficient in-network mental health providers, mostly on the outpatient level. If you've ever tried to find an outpatient therapist who's in network, and you found one, please let me know, because they're few and far between. Less so on the residential side and in the partial hospitalization side. There are some you can find, but certainly not enough. And it is part of the mental health crisis that you hear about all the time in the news. Okay. Okay, so if there's no more questions on that topic, I wanted to turn to another topic that I found interesting this week, and put a little plug in for something that we do at Kantor and Kantor. Every month we publish something called ERISA Watch, which is a summary. I'm sorry, Julie, we do it every week, right?
Yes, we do it every week.
Right.
That's all right.
It's a summary of every important case that's come out the last week. And a lot of times these cases have to do with pension issues, disability issues, but they often also have to do with health issues. And I was reading this week's, so if you're interested in receiving ERISA Watch, you can reach out to Julie and she'll put you on our email list, our subscriber list. And you know, a lot of these cases may not have anything to do with you, but there's every once in a while, and I'd say at least once a month, I find one that has a real pearl of wisdom for those of us in the health side, on the health side. So this week I was reading the opinion of the week, which brought up a question that people are constantly asking me. So this case had to do with a man who had a very large health claim, and his employer did what we call self-funded their health insurance. And we've talked about what that means. So instead of buying an insurance policy, his employer, a large employer, decided that they would put money in a bank, basically. And instead of paying premiums, they would just hire an administrator who would administer the money in the bank. So after his very large surgery, very expensive surgery, he was terminated. Now, there is law that says that there cannot be a negative action taken against you as an employee for exercising your ERISA rights. But I know that even people with insured plans, almost everyone who calls us with an ERISA claim is worried that their employer is going to be angry at them, first, if they appeal a decision of a denial, and most importantly, if they sue. And I understand that concern. It used to be that you had to sue your plan. Now, we've talked about this in the past, and the way the law was written, as soon as Kantor and Kantor, for example, decided to provide health insurance, a fiction arose in the law called the Kantor and Kantor Health Welfare Plan. And it used to be that, if Lisa Kantor wanted to sue because my surgery wasn't covered, I had to sue Kantor and Kantor Health Benefit Welfare Plan, even though it really didn't exist, and even though we had a policy with Cigna. Luckily, more recently, we don't have to do that. We can just sue the insurance company directly. But of course, your employer finds out. And, people are very concerned about this. And I understand why. And even when I explain to them that the law protects you and you can't be fired and you can't be disciplined and you can't be demoted, they look at me and say, yeah, well, you can say that, but I'm the one going to work every day. And I completely get it. One of the things we try to do at Kantor and Kantor with self-funded plans where there's a denial and we're trying to help an employee work through it is we recommend that they go to their HR department first. And they say, hey, can you help us? Can you help me with our insurance company or with our plan administrator? Because I'm not getting what I want. And this is a lot of money and I can't pay for it. And I'm sick and can you help me? Now, a lot of times that works. And a lot of times it doesn't. But at least with that interim step, employees feel like they've given their employer the opportunity to do something different. So this case this week, this employee felt like he was fired because of his large surgery. He sued his employer. And interestingly enough, the jury, because there were state claims also, it went to a jury. The jury concluded that he did not have a claim for retaliation or wrongful termination, but the judge concluded that he did and decided that he was entitled to his lost salary and other pretty significant damages because his employer retaliated against him for using his health benefits. You hardly ever see a case like this. I can't remember the last time I've seen a case like this. And it's inspiring and it gives me hope. So I hope it gives all of you hope that there are laws out there that protect you and you can find lawyers who can support you when they're violated. It doesn't mean it isn't terrifying in the moment. And that's why we try to spend a lot of time at the front end working with people to see if they can work through this, before they have to go to court and feel uncomfortable in the workplace. So there's a question here about a complaint with the Department of Labor on a self-funded plan. It's a really good question. So let me just give all of you a little background here. So remember, we talked a minute ago about networks and policies having to report to state agencies. ERISA policies are governed by federal law, and they are regulated by the Department of Labor. And in particular, self-funded plans, the only place that there's any regulation is from the Department of Labor. The Department of Labor has a kind of an interesting history in helping people when they can't get relief from their plan. I have seen it used incredibly effectively in spotty instances. And then other times I've seen really legitimate complaints being brought to the Department of Labor, and they do absolutely nothing. It is the head of the Department of Labor is a political appointment, and so of course it blows in the wind of what's going on in politics. And of course, it also depends on who you land, who answers your phone call. Unfortunately, they have some advocates who will dig in and really help. I saw this happen once in New York, and once, believe it or not, in Texas, where the advocate got the company to reverse decisions. But I have to say that was quite a while ago. And Joy is responding, I've tried a lot of times with no success, and I'm not surprised. Interestingly enough, the other thing I was going to talk to you guys about today was that I just saw that the Department of Labor has filed a lawsuit against United Healthcare over emergency claim denials. Now, it is very rare that the Department of Labor actually sues health insurance companies. You think to yourself, how could that possibly be? This is part of their job. Well, again, I don't really know. We have a lawyer in our office, Liz Hopkins, who used to work at the Department of Labor. Boy, she's been with us now for quite a number of years. And when she worked there, we worked together on a number of issues. And I think that version of the Department of Labor was once much more consumer oriented and much more active. And I think Liz will even tell you that there aren't those kinds of people in the department anymore. But here's a case where the Department of Labor is suing United Health Group over emergency claim denial, saying that emergency room, but also urinary drug screening claims are being improperly denied by United Healthcare, and that they want them to reprocess all these claims from January 1, 2015 to the present. Now, first of all, what struck me about this was the power that this agency has that they could be using, because they are the only ones who could say to an insurance company, unless those of us in this industry win a class action, they're the only agency that just come out and say, reprocess for the last 8 years. How powerful is that? It also brings up an issue that I've seen before, which is the use by insurance companies of these automatic what they call auto processing, auto adjudicating programs, and their misuse of it, where they kind of design it so that it auto denies certain types of claims. And I've seen this happen many times, where all of a sudden an insurance company will say, you know what, we're getting too many urine drug screening claims, and we're just paying them. We want to auto deny them and ask for documents in support every single time. Now, I've argued in many cases that that's just wrong. It's bad faith when you're in state court. It's breach of fiduciary duty when you're in federal court. There hasn't been a lot of good case law or support for that theory that I'm using. But here we see finally the Department of Labor saying exactly that. What they're saying is that United Healthcare just started switching their denial codes for urine screening to a request for medical records every time. We don't think it's medically necessary. You prove it. And United Healthcare, in the article I read, said, well, we haven't, we changed that back to a normal procedure. We haven't done that for a long time. So, okay, maybe we'll go back and fix it. I don't think a lot of people realize, you know, that the implication of something like that and what happens, and maybe some of you have encountered this. So all of a sudden, a doctor's office that does drug screening, everything is getting denied. Their income is stopping cold from this one insurance company. They're having to gather medical records for every single time they do something, which is cost them money and cost them time. They're probably reaching out to their patients and saying, look, we're not getting paid anymore. You're going to have to start paying us, which affects healthcare. So it goes all the way down the line. And insurance companies, you know, they're doing it for money reasons. They're doing it because, you know, we don't want to pay this because we've decided there's too many of them, not because for any individual person they've decided it's not proper. I think that, you know, Joyce is making a comment that a lot of people just accept denials rather than pushing back. And, you know, we talk about that a lot in this webinar. And I, you know, I have to say, I fall in that area sometimes myself. I mean, how many of us have the time or effort that we want to put into, you know, a $50 charge from an insurance company? You know, many of us will just say, I'm just going to pay it. I don't have the energy for this. Well, just imagine, I think that I'm trying to remember what the numbers were, the number of insured lives in California. I remember the last time I looked at Health Net's numbers. They had about 3 million insured lives in some period of time. And just imagine if every single one of those people pay a $50 charge that they didn't have to pay. I mean, you know, it is a strategy that they use, just like their UBH is using it, United Healthcare is using it, in this case by the Department of Labor. Let's see what happens if we deny, how many people push back. And I had a recent example of that myself. I had a charge from a anesthesiologist. I had my pacemaker battery was replaced some time ago. And I looked at it and I noticed that there were 2 different service dates. And I only, you know, if you ever had a pacemaker, it's an outpatient procedure. I mean, you're under anesthesia, but you go in, they put it in, you go home. It's only 1 day. But the bill came in for a date in April and a date in May. So I emailed first I called and then I emailed the billing company. And I said, I don't understand how you're billing me for this other day. Well, our records show that you were in the hospital for, you know, and you had anesthesia on this day. I said, well, I didn't. Can you tell me the name of the doctor who treated me? No, I can't tell you that. Can you send me the medical records that support my treatment? No, I can't do that. You're going to have to call the hospital. And this is all over $82. Now, you know, I really tried hard not to just give in and pay it, and I haven't paid it yet. But imagine, I mean, I'm somebody who does this for a living, and I'm getting frustrated, and I'm ready to just throw in the towel. And imagine what happens for everybody out there who gets a small charge. I mean, some of these charges are really small, but it's the way that insurance companies just make sure they keep generating income. So good for all of you for pushing back. And if you want help and advice on how to push back, I'm much better at telling you how to do it than I am for doing it for myself. But I'm trying to set an example and work on that more for myself as well. So any questions about that or any comments? So I want to also talk today about another topic that's kind of related to it made me think of it when I was reading this article on United Healthcare. And I think we've touched on this before, but it has become so important in so many areas of healthcare that I think it's worth talking again. And that's the issue of what is medically necessary and who gets to decide what's medically necessary. You know, there is nothing more infuriating to a patient than going to your doctor and having your doctor say, you need X, we need to do X, whether it's a medication or a treatment, and having your insurance company say, that's not medically necessary. It makes no sense. Why wouldn't what your doctor said be medically necessary? It's a really hard concept to understand. Insurance companies just say medical necessity is a coverage term. What does that mean? It means that we get to decide what medical necessity is, and you need to read your policy. Okay, so when you read your policy, every policy will say something like, what's medically necessary is what's the standard of care in the community. And for a lot of things, there's not a lot of disagreement. You know, you break your arm, you have an x-ray, you need a cast. Pretty standard, straightforward. But it's, you know, a lot of doctors will tell you, a lot of medicine is an art, not a science. And your doctor is working with you and has seen you and understands you and may have tried one thing or another and wants to try something new. And you want to feel like you can be part of your treatment and part of your plan. But what insurance companies do is, in addition to that general language in your policy, they have pages and pages and pages of guidelines that define what medical necessity means in almost every example you can think of. Every medication, they have a guideline. Sometimes they're 10 pages long. Every procedure. And so they take that pretty straightforward language and they have committees and they work on this every year and they have these very complicated guidelines, a lot of which are very difficult to understand. But what we're finding, and this is why I'm bringing this up to you, is that a lot of times these guidelines are out of date. They have not kept up with what's going on in medicine. And honestly, who's keeping up with what's going on in medicine? The people who are treating. But the people who are treating are not working for insurance companies. Those are usually different doctors who are not treating, and they're usually behind the times. One of the areas we're seeing this a lot is in cancer treatment, believe it or not. You know, I remember, this will tell you how old I am. When I first started doing health cases, that getting an infusion, a stem cell or what's it called, an infusion for cancer treatment, was considered experimental. Now, you know, that's done pretty often. So now we're seeing that there's especially one type of cancer treatment that we deal with a lot called proton beam therapy that has been around since the 40s. It is not a new treatment, but insurance companies are deciding that it's not medically necessary and that people can just use regular radiation. Well, why do I care about this? Why should you care about this? Proton beam is a directed radiation that goes straight into where the tumor is or the cancer is. Regular radiation, what we understand to be radiation, is more scattered. So let's imagine for a moment that you have a tumor in your breast. If you spray radiation against your chest, you're spraying radiation against other organs, against your heart, maybe your lungs, and other things that most doctors will tell you, you do not want radiation on those things. Proton beam will just attack the tumor. So most doctors will say, for particularly neck, head, chest tumors, you should not be using regular radiation. This comes up a lot, believe it or not, with men with prostate cancer, because prostate cancer is very common. It is very curable, but if you use general radiation on prostate cancer, you have a very high chance of creating bladder cancer. And the studies have shown that this is what happens. And I can tell you, I went through this with my dad. He had prostate cancer, and then he developed bladder cancer from having general radiation. When you use proton beam therapy, your chances of getting bladder cancer are much reduced. But here we have an example of the internal guidelines not keeping up with what's going on in actual medicine. So why do I raise this with you? One of the things you're entitled to, if any insurance company denies your claim, is to get a copy of what they're using internally. They may say in their denial letter, we do not believe this is medically necessary. And they may or may not reference an internal guideline, but you're entitled to ask for it. Unfortunately, they're not that easy to find before you have a claim denied. And a lot of people will not even get them after the claim is denied. And so they'll go all the way through the process and come to us without ever analyzing that issue. And sometimes, not all the time, if you can look at that internal guideline and give it to your doctor, then you can correct whatever it is they're pointing out that they think you don't have, that they think you can't do, that they think you can't prove. Now, many times, and especially in the proton beam area and in a lot of mental health areas, their guidelines are just impossible. And you're going to see when you look at them, there's no way I can meet these. That's especially when you should call us, because we've done a lot of work in challenging internal guidelines. We're actually working on a proton beam class action right now. We're trying to get one insurance company to change their internal guidelines on proton beams. We've worked on some mental health issues where we've gotten insurance companies to change their internal guidelines on how they view residential treatment, for example, and what you need to do to qualify for that. Where I always want to try to take cases to courts where we can get that kind of across the board change, because that will help not only you, if you're the person bringing the case, but everybody out there. Yes, so Joyce, you're asking for a copy of their internal guideline related to whatever it is your issue is. So if you're asking for, I want a pacemaker, what are your internal guidelines on pacemakers? If you're asking for a particular drug, what are your internal guidelines on drugs? There was a really interesting, fabulous case that came out of Northern California that made a new definition of what internal guidelines should be by reference to standard guidelines in the community. So for example, if you're talking about addiction, you have to use what we call the ASAM, American Society of Addiction Medicine guidelines. Unfortunately, that case is in limbo at the Ninth Circuit right now, and we don't know where it's going to come out. We always argue that insurance companies' guidelines, first of all, argument number one is they should be using recognized medical guidelines. So if the American Cardiac Association has a guideline, they should use that. If the American Orthopedic Association has a guideline, they should use that. They shouldn't be making up their own. What that does is create confusion and inconsistency between what medically necessary is, and it violates what your expectations are when you buy insurance. When we can't get that across, then what we've done in a lot of different areas, and maybe it's an area you're interested in, is compare what guidelines are out there to what's in the industry and sort of critique what they're doing, to say why they can't do what they're doing. I think I've told you this story before, that I was in a trial once, and basically the person from the insurance company identified 17 criteria that someone had to meet to get residential treatment for mental illness, and that they were disqualified if they had what he called a normal dysfunctional family, meaning anybody at home, a warm body, who could watch the person at night, because then they didn't need overnight care, which was, it was an extreme example. But I bet there are others out there. Joy is asking, if they're making up their own, how does that not fall under dictating care? I would argue it does. And we often make the argument that this is what we call the corporate practice of medicine. That insurance companies are not supposed to be dictating care. What they're doing when they say that what's recommended is not medically necessary, they're dictating care in practicality, because who of us can afford expensive care if our insurance doesn't pay for it? I have to say, Joy, I love your argument. I make it all the time. It has generally been a losing argument, because going back to what I said before, insurance companies say, medical necessity is not a care term to us, it's a coverage term. This is what we cover. And I have a real problem with that, because first of all, it's using words that we all understand in a certain way. And second of all, the practicality, as I mentioned, we can't afford healthcare if our insurance doesn't pay for it. That's the way our system is set up in the United States. And third, how could anybody understand that you're buying health insurance that doesn't cover what doctors say you need? That, to me, you're selling a false policy. You're selling something that's fraudulent, because it's not what people are understanding they're getting, and it's a fundamental problem with the way our healthcare system works, because insurance companies have gotten away with this argument. So a lot of times what we have to do is attack it on the particular procedure, or medication or whatever it is that we're looking for, and drill down in the minute part rather than the big issue. But Joy, we've tried that. I try it, I still do it, but then I have to make sure I can also support it with medical articles that show the judge, in this case, they're wrong, even if you don't buy it on the big area. So we're getting close to the end here. I don't know. Oh, Joyce, are you saying this? Oh, right.
Yeah, thank you, caught it.
Okay. Yeah. Yeah. We've done a lot of work, and Joyce was one of was along for the ride in one of these, but we've done a lot of work changing the way courts look at things, and when we change the way the court looks at it, then the insurance company has to change as well. A lot of our work has been in the mental health field. I'm very passionate about mental health coverage, and I think that there's still so much more work that needs to be done in that area. But we've made some strides in changing the way things are done. One of the things that Joyce and I, dealt with, and that people still deal with, or, is Joyce said, how can they be dictating care? It's bad enough that they're dictating care, but they're often dictating care based on doctors who are incompetent to issue the opinions that they're issuing. Not only are they not in the right area, I mean, we've gotten, podiatrists opining on mental health, or what was my favorite one? There was a OBGYN who was talking about a mental health case. I mean, they at least need to have the right qualifications. But then when we dig behind those qualifications, they need to have the experience. I mean, just because, look, I'm a lawyer. If somebody asked me to draft a will and I did it, I'd be committing legal malpractice. I don't know how to draft wills. I know what I do. I deposed a doctor once who was giving me an opinion, or had given an opinion to an insurance company on whether a young girl needed mental health treatment. And I asked him what his definition of anorexia was. And the definition he gave me was when someone goes on a hunger strike, like when I used to work in the jail, and the people, they wanted to get out of the jail, so they stopped eating. And when I pressed harder to see if he understood that anorexia wasn't just a decision not to eat, he denied it. He said, it's just, if you or I decided tomorrow we were going to start fasting, we would have anorexia, which, if you've been involved with that disease, is not even close to correct. So on top of practicing corporate practice of medicine dictating care, we have people like that who really don't know what they're talking about, opining about things they shouldn't be opining about. And of course, the issue of, they never looked at the patient, they never met with the patient, they have no idea what the particular issues are with the patient. So I'm gonna stop talking for a few minutes, see if anybody else has any questions or any comments. I see that Andrew is here today. Andrew is a lawyer at Kantor and Kantor. He's also my oldest son. Glad he's joining us today. And he has a lot of ERISA experience, especially in the disability side. So I always love to have him attend. I didn't know, Andrew, if you had anything you wanted to say.
I can tell my mom's a little mad at me because she called me her oldest son and not her favorite son. But beyond that, no, nothing. If everything that my mom said about health insurance questions, all of that, we haven't had a chance to talk about any disability insurance. But the same thing applies. If any of you come across a disability insurance issue and have questions, you can always feel free to reach out and email us. And I or my father will be happy to do what we can to help. One of my favorite parts of this job is that we are encouraged to have conversations like that with people. And if even though 7 out of 10 times it doesn't result in anybody needing to sue anybody, and thus we just get to help people because we can help people, just because this is what we do, it's described as good business. So I'm able to take these phone calls and spend my day talking to people and helping, and I get to trick people into thinking I'm actually working. So please feel free to reach out, and maybe we'll have one of these series one day about disability insurance, and I can talk for 45 minutes and wow you with my knowledge. But I think everything that's said was pretty spot on. Not that I'd be the one to say it because you are, but thanks for attending.
Thanks, Andrew. And we are going to do a disability session one time this fall. I don't think we've set it yet, Julie, but we will set it so we can do a disability session. Good.
Yes. Yeah.
Joy, I'd love to speak with you further. Medicaid is an area that I don't know a lot about. I don't get I would love to speak with you further and see how we can help each other. I have worked with a lot of facilities who work with Medicaid, and I know that it's a very complex process to get Medicaid authorized. Sometimes it works by county, if I'm not wrong, Joy. So would love to hear what you have to say either now or privately.
Yeah, it is a nightmare, to say the very least. And no facilities are not taking Medicaid at all anymore because of it. So even if you get a single case agreement or a pre-authorization, when it comes time to billing, especially if it's somebody like Blue Cross Blue Shield Medicaid, say like Minnesota, they will give the pre-authorization, but then when it comes time to billing, they'll deny it. And so these places are racking up big bills that Medicaid won't pay. So it's becoming very problematic. Yeah. And because, like you said, it can be all the way down to county. Getting any kind of oversight over it it's chaos.
Yeah, let's talk, Joy. I would love to talk with you further offline. It's an area I haven't dipped my toe into yet, but I'm hearing the groundswell of, people like you. I've had other calls from people saying, can you help with this? So it may be time for me to educate myself and see if I can help, because it's yeah.
It is, and especially Blue Cross, a lot of the old practices, or even United Healthcare, a lot of their old practices that they used to do with ERISA and parity violation, they're now doing blazingly open on the Medicaid side.
Interesting.
It is. Yeah. It's completely rolled over on the Medicaid side, like back to 1990. One thing I would be interested in, if you guys were ever open to having a conversation around extending insurance coverage for somebody who's chronically ill. So somebody who's had their parents' coverage and they're coming up on that age limit.
Yeah.
I don't know if that's anything you guys talk about, or you talked about disability insurance, or if that's in your wheelhouse.
Yeah, I've done that a number of times with people. And so it is often policy driven, but when you come up on that, we're Cal Cobra, so it's age 26. There's usually a provision that you can prove disability and keep the dependent on your coverage. And I've actually walked people through it a couple of times. So yeah, let's set up a time to talk about that. I'm happy to, share with you what I've done in the past.
Well, I've done a lot of them, but I have a question over that. Is there a uniform guideline for them, or is it just company to company, whatever they decide?
Yeah.
But I don't think people realize that they can even do it.
I think you're right. People do not realize they can do it. I think having Affordable Care Act out there has made a lot of people think, well, I'll just buy a policy, and they don't really think about what does that mean. But I haven't seen any uniform requirements, although off the top of my head, I would think there must be one. But let's talk about it, because that would be a very interesting area to sort of talk more about.
Because my guess is on the legal side, you guys will start seeing this, because I've got 6,000 people I am pushing it down their throat on a daily basis. So
wow. Okay. Yeah, let's set up a time to talk, Joy.
Okay, awesome. Thank you.
I put Lisa's email in the chat area for everybody, but just so you know, it's L for Lisa, and then her last name, Kantor, at kantorlaw.net. So that's a hard one to mess up. That's a super easy email there for everybody. I think that kind of wraps everything up, Lisa. Great information today. Smaller crew today. I think August tends to be the one where everybody goes on vacation. They all want to go somewhere cooler or more tropical, but what a valuable amount of information today, and really appreciated the audience interaction, because it just pulled out more information, more education. All right.
Thank you, everyone. Take care. Bye-bye.